and the meeting is also streaming in YouTube live now.
Yes, we are live on YouTube.
How are you?
Dr. Arif, you may start. Thanks from Ortho TV and
Yes,
Dr. from India. Now I'm handing over to Dr. Arif to start the meeting.
Yes, sir. Can you just transfer the host status, sir?
Sure. Yeah, done. You can start.
Okay. Oh, sorry, sir. Bari sir, can you hear me, sir?
Yes, you can start now.
I can start. And
Yes,
now I request Abdullah, please share your screen. I already enabled the screen share.
Is it okay, Dr. Arif?
Yes, it is visible to us. You can start now, sir.
May I can start, Dr. Bari, sir?
yes, you start. Already you have given the permission.
Thank you, sir.
Bari sir.
Walaikum assalam wa
I just a minute, ASM Abdullah. I request everyone, please mute your microphone on entry so that there is less noise. Sometimes I also have the capability to mute all the participants. Better you mute your microphone on entry. And ASM Abdullah, you can start now.
Thank you, Dr. Arif. Welcome to our basic Ilizarov webinar session conducted by Bangladesh Kurgan Fellow Group. Today, my topic is fracture geometry, types of displacement, and destruction technique. My lecture number is 10. I am Dr. ASM Abdullah, Fellow RISK RTO Kurgan and Fellow Joint Replacement India. Good evening to everyone. Special thanks to Dr. Samsuluddha sir from India. And this is our professor, Honorable Professor, International renowned Ilizarov surgeon, Professor Bari sir at Kite City, Shandong, China. Though in this situation, COVID situation, it is very difficult to maintain the daily academic activities. The webinar session will help us to maintain our academic activities. Gabriel Abramovich Ilizarov is the man, the creator, the teacher. He made possible all fracture difficulties by ring external fixation. Tension stress during gradual living tissue, extension activities, and maintenance as a natural result active regeneration and growth of tissue structure during the entire process of factor validity. This is the quote of Gabriel Abramovich Ilizarov, which is at the black stone of the monument of Professor Ilizarov at Kurgan Center. This is me at Kurgan Center. We are the 7th Kurgan Fellow at Kurgan last April. Now let us start the academic session. What is fracture displacement? After complete fracture, the bony fragments usually become displaced. It may be due to force of injury, gravity, and pull-up muscle. The types of displacement, many types of displacement occur at the fracture site. They are translation, where fragments may shifted sideways, backward, or forward in relation to each other. Angulation. The fragments may be tilted or angulated in relation to each other. Their malalignment, when, if uncorrected, may lead to deformity of the limb. Rotation or twist. If one of the fragments may be twisted on its longitudinal axis, the bone looks straight, but the limb ends up with a rotational deformity. Here the cursor, the rotational deformity acts on the bony fracture and the rotational deformity. Then length discrepancy. The fragments may be distracted and separated, or they may be overlapped due to muscle spasm, causing shortening of the limb. Now, how displacement correction by Ilizarov method. Here, multiple option. In this picture, here the angular deformity of the femur is corrected by proximal arch and distal ring connected with long plate and also graduated telescopic rod. Here, two half ring act as a puller and pusher device. In this deformity, in this displacement of this fracture, here using long plate connected with a ring as a translation device. In this picture, the transverse translation occur by the two long plate. Here fibula is translated in the long axis of the gap of tibia. In rotatory deformity or rotatory displacement of this bony fracture using derotation translation device, using here conical os are used and threaded rods are connected with two rings. Here posterior displacement in this picture, the posterior displacement occur in the tibia, which is corrected by translation device. The translation device used in the posterior displacement, here 4 rings, 2 rings in upper fragment and 2 rings in distal fragment, connected with the translation device. The cursor shows the translation device. In this translation device used by horizontal threaded rods and multiple posts. Here, in the direction of this arrow, the displacement corrected by this way. Then let us know what is the biology of limb lengthening. Gabriel Abramovich Ilizarov states the law of tension stress. It states that when living tissue are subjected to the graduated planar distraction, force in the presence of intact function and vascularity, and the bone is subjected to a low energy osteotomy or corticotomy. The necessary ingredients for successful lengthening is stability of fixation. The stages of limb lengthening, there are 3 phases. Latency, it means after corticotomy, the 5 to 10 days after surgery, depending on the type and gentleness of the osteotomy or corticotomy. Then distraction, lengthening is done at 1 millimeter per day till desired length is achieved. Then consolidation, the soft bone that forms need hardens and cortical tube is allowed to form. This phase may take as much as twice as long the destruction phase. Then, what is destruction osteogenesis? The destruction osteogenesis, also called callus destruction or callotasis, and osteodestruction is a surgical process used to reconstruct skeletal deformities and lengthen the long bones of the body. Destruction osteogenesis has the benefit of simultaneously increasing bone length and volume of surrounding soft tissue. In 1916s, Professor Gabriel Ilizarov introduced and developed the method of destruction osteogenesis. What is the pathophysiology of destruction osteogenesis? Destruction osteogenesis is based on the tension stress theory of Ilizarov, which states the slow, steady traction of tissue cause them to be metabolically active, resulting in increase in their proliferating and biosynthetic function of osteogenesis. The lengthening of deformities correction by the method of destruction osteogenesis, tension stress effect that permits the development and formation of new tissue and treatment of many complex injuries and disease of the locomotor system. Now, method of destruction is used primarily for the bone lengthening, for the correction of bone deformities, for bone segment transport. The regenerative process depends upon the two main factors, the adequacy of local blood supply and the stimulating effect of micro vibration of the tensioned wire. Here, this slide shows the phase of destruction osteogenesis. Here, osteotomy done, and the destruction process will continue. After destruction up to the achievement the length, then consolidation starts. Quality and quantity of the newly formed bone depends upon the several factors. Number one, the rigidity of bone fragment fixation, the degree of damage of the bone marrow, the periosteal soft tissue, and the nutrient blood vessels at the level of osteotomy. Number three, the speed of destruction rate, the rhythm of frequency of a destruction. Number five, the distribution of force on the bone circumference. In destruction site, neoangiogenesis occurs here. Active angiogenesis occurs during the latency and destruction period. Blood flow 7 times normal within the first 4 weeks, then 3 times normal next to 3 months. Angiogenesis at corticotomy site has a role of treatment of Burgess disease by lateral transport. Here, the picture shows many neoangiogenesis occurs. Types of osteogenesis. Mostly intramembranous ossification without end condyle ossification. Here, central zone type 1 collagen, no type 2 collagen, which is common in end condyle ossifications, because in destruction osteogenesis, intermembranous ossifications occurs. It depends on the stability of the fixator and the vascularity of the surrounding tissue and rate and rhythm of destruction. Here the histology of the destruction osteogenesis. In this theory, 3 zonal structure of the destruction regenerate. Here the 3 zone, the radiolucent fibrous interzone, maximal influence of tensional stress, highly organized, longitudinally oriented, and parallel bundles of collagen. Here, spindle-shaped fibroblast-like cells are seen. In this region, 2 radio-opaque zones of primary osteon formation adjacent to the residual bone fragment, longitudinally oriented cylindrical primary osteons that grow toward each other. In another, the 5 zonal structure of the destruction regenerate. Here also radiolucent fibrous interzone, which previously told the last slide. And this, the 2 radio dense zones of primary osteon formation. This is called zone of osteoclarosis, zones of sclerosis. In this region, two radiolucent zones of remodeling adjacent to the residual bone segment. Now, what is the types of lengthened callus? Lengthened callus. In the radiographic appearance of the lengthened callus is 6 types. Number 1, the external. This is barrel-like fusiform callus, wider than the original bone. Number 2, straight, homogeneous callus, just as wide as original bone. Number 3, attenuated callus. Here, callus narrower than original bone. Opposite, callus formation or maturation, mainly the opposite side of lengthener. Number 5, the pillar callus. Here, poor callus only in central portion, and agenetic, only sparse calcification in the gap of the bone. This is the picture of, diagrammatic picture of the 6 types of lengthened callus. This is the external callus, which is fusiform shape. This is the straight, the original bone resembling that, and attenuated. And this is the opposite side. Here, the callus is formed in the opposite side of the lengthener. This is the opposite side of, this is the same side of the lengthener. And this is the pillar type of callus, and this is the agenetic. Here, sporadic, some calcification in the gap. This slide shows the radiographic feature. Here the fusiform-like callus, and this is the straight type of callus. And this is the attenuated type of callus. Here, the opposite type of callus. And this type of callus is seen, some portion, this is the pillar type callus. And the most least the callus is found in the agenetic type. Depending on the degree of circulation, the callus formation is vary. If good circulation is available, here bone tissue is regenerated. If weak circulation, fibrous connective tissue is found. If diffuse nutrition, cartilaginous tissue is formed. What is the rate and rhythm of destruction? Professor Gabriel Abramovich Ilizarov established the optimum destruction rate as 1 millimeter per day, divided by the 4 times with the rate of 0.25 millimeter performed every 6 hours. If 0.5 per day, it offends drives to premature consolidation. If 2 millimeter per day, it offends results in the delay of new bone formation or non-union. So the optimum destruction rate is 1 millimeter per day, which is followed by the all Ilizarov surgeons. Wait, the speed of the rhythm, speed and rhythm, the destruction are adjustable. With periodic control, they have to be changed up to 1.5 millimeter per day by the 6.25 millimeter per turn, especially for the kids and young healthy patients. In some cases, they have to be reduced to 0.5 millimeter per day by the 2.25 millimeter by turn, mostly for the patients with osteoporosis. The optimum distribution of destruction force is point of application with 90 degree between them. Then, what is the site of lengthening? Commonly, we perform a corticotomy at the metaphysial region. Here, metaphysial lengthening leads to better osteogenesis than the diphysial lengthening. This picture shows the nutrient vessels in all long bones. This is the tibia, femur, humerus, and radius anula. In the metaphysial region, the blood circulation is more than other part of the long bone. Method of destruction. There are two ways to perform destruction. Applying two number 10 wrenches simultaneously loosen and tighten the nuts by quarter of turn. Number two, using the graduated telescopic rod, which has a rotating head and a riser mechanism. We know the 1/4 of the turn corresponds to 0.25 millimeter of destruction. Here, the nut shows the full turn of on. It resembles 1 millimeter of destruction and compression. Here, the ring and the threaded rods and nut, the direction of destruction. In this slide, this is a shot of the nut, quadrangular nut. We told previously the corticotomy, after corticotomy, the lengthen we follow 4 times in a day. In this quadrangular nut, one turn into 0.25 millimeter destruction. Here, using telescopic rod in the lengthening bone transportation. Here also the telescopic rod system. Now the destruction osteogenesis. Here 4 steps involved. Number 1, corticotomy or osteotomy. Number 2, latency period. Number 3, destruction. Here destruction also follow the rate and rhythm and the consolidation phase. Here I want to show the a diagrammatic picture. After osteotomy, the latency period 3 to 7 days. Then we can destruct the bony fragment by 1 millimeter per day. After achieving the length, then consolidation period starts, which is also called mineralization. It will 6 to 10 weeks. After consolidation, the removal of destructor is possible. Here shows the destruction. After destruction, there are the apoptosis, which is also called cell death, and also BMP activation. It also some system activated, which all systems follow the neoangiogenesis. The neoangiogenesis in the metaphyseal region, the bone cell proliferation and differentiation occur, and the new bone regeneration. What is corticotomy? It is a low energy osteotomy of cortex, preserving the local blood supply of both periosteum and medullary canal. The type of corticotomy, it may be unifocal, bifocal, or multifocal. What is the ideal corticotomy characteristics? It may be long oblique, metaphyseal in situation, no comminution, no disruption of endosteal and periosteal blood supply, which is fixed in anatomical position with gap less than 2 millimeter. Here, the bone transportation after corticotomy and this zip file, the destruction is shown. What is the advantage of destruction osteogenesis? Number 1, relatively simple operative technique involving bone lengthening and soft tissue. Number 2, avoidance of bone grafts. Number 3, multidimensional destruction. Number 4, shortens hospital stay. We know after corticotomy, we teach the patient how destruction he follow. Number 5, good long-term stability, and it is also cost effective. What is the cause of failure of destruction osteogenesis. Number one, ischemic fibrogenesis. Number two, inadequate blood supply during destruction. Number three, cystic degeneration. Number four, unstable fixation where microfracture, hemorrhage, and cartilage interposition occurs. Number five, buckling or bending the regenerated bone. Number six, occurs when fixation removed prematurely. And infection, and last one, old age. There are also others, many types of factors. Now, what is the contraindication of transosseous osteosynthesis or destruction? Number one, diseases of vital organ at the stage of decompensation. Number two, severe mental disorder and large affection of the skin and purulent process. And last one, the subperiosteal fracture and fracture in children up to 1 year of age. This is my case. My patient attending to me, the X-fix of the tibia in open fracture in gastro type 3B, which is managed by elsewhere. After removal of the X-fix, there is a large bone segment, which was sequestrum. I perform wide debridement of the unhealthy tissue and the unhealthy bones. After that, the next sitting, I perform corticotomy at the metaphysical region. And after 3 or 5 days, I destructed the bony fragment distally. After that, this is the callus formation is shown in this picture. Now this patient is waiting for ring removal. This is the picture of last Assamicon, which is held in New Delhi with Professor Junjunwala and where the Bangladeshi Ilizarov surgeon and Professor Dorpeleser and with Dr. Arif, Dr. Subro, and me. We're the 7th Kurgan Fellow of Bangladesh. This is the last, and I want to complete my session. And next session, and the lecture number 11 by Professor M.M. Barisar on the interesting topics of basic ideas of deformity, which will be held 9 June 2020. You can enjoy our session in YouTube also. Also, if you enjoy this session, you must subscribe to the Ilizarov Clinic, KUMC, and Ortho World. It also live in Ortho TV. And many, many thanks for patients hearing my webinar session. Thank you to all.
Thank you, Abdullah, for your nice presentation. Especially there are more details about the destruction and other issues, and nicely histological and other pictures and and physiological basis of destruction. I think everyone will get the more valuable information from here. And also important thing is I noticed that you also mentioned some contraindication of destruction osteogenesis. Usually we cannot get this type of information frequently. So I request to please stop sharing of your screen so that we can go to gallery view. There are many questions awaiting for you. I think everyone will enjoy the session, and I am requesting everyone, because destruction osteogenesis is a basic principle of Ilizarov. So everyone have some opinion or his knowledge or problems with the distraction. So we can share the knowledge today and can have a very good academic session today. So Abdullah, please stop your sharing. Uh, please, so that I can go to gallery view. Abdullah, please stop your sharing. Screen share. And you can see the step sharing is at the upper part of your screen. There is a stop sharing, the red icon. Stop screen share. Okay, thank you. Stay connected, and there are many questions waiting for you. I am going to Professor Mufakkarul Bari. Please, sir.
Probably, Arif.
Yes,
probably, probably you allow the participants, those who can ask the question to the presenter. Otherwise, you will forget by this time.
Sir, just you please keep commenting on his presentation. There are some messages in my chat books. I am just go through it, and with a few minutes, we will come back for question answer session, sir. Sir, you
okay.
Please. Yes, sir.
You want to pass my comment first, eh?
Yes, sir.
Okay. Okay. Abdullah, thank you very much.
Thank you, sir.
Thank you very much for nice presentation. Elaborately, you said everything almost. I want to add only something regarding the, it's very important, the bone displacement. Then you have rightly mentioned everything. Destruction, osteogenesis, biology. There are very important things regarding the biology. If you think about the biology of, you also rightly mentioned. And regarding the name of the professor, Gabriel Abramovich Ilizarov, this is a Russian name. That's why if you don't know the Russian language, it's very difficult to pronunciate the exact name. Gabriel Abramovich Ilizarov. That is his full name. In English, if you say Gabriel, that is Jibril, Abramovich Ibrahim. In English, if you see this, and Ilizarov. So this is his full name. Now, I would like to mention, you rightly mentioned regarding the destruction osteogenesis. It's very important. Mechanical induction of bony surfaces that are gradually controlled or distracted in a gradual and controlled manner. This is destruction osteogenesis. Destruction osteogenesis. In Russian, they call it destructiony osteogenes. And the term came from the Professor Ilizarov. Nobody told before that what is destruction osteogenesis. Now, regarding the biology, you mentioned everything. Only I want to add something. Whenever you see in histology you also mentioned that one. And you know, these mesenchymal cells are forming there, okay? And when you can see in histology, mechanism of bone formation, you also mentioned this is intramembranous bone formation, right? You mentioned that one. And endochondral bone formation, less common, endochondral less common, but you can see this in the fibrous interzone also. And you also mentioned that one also. And trabeculae, regarding very important, the trabeculae looks like stalagmites. You know, the ray coming to the hill, just like a stars, stalactites and stalagmites. The trabeculae looks like here. And interzone has the undifferentiated mesenchymal cells in this destruction osteogenesis. Whenever you go for faster lengthening, if you go faster lengthening, you will create ischemia. If you go slower lengthening, you will not get good regenerate bone formation. So Professor Ilizarov, biological parameters of Ilizarov, not only Ilizarov, for any external fixators is 1 millimeter per day, but depending upon the quality of the bone and the destructive traumatology, destructive trauma, if you go for corticotomy, you have done the destructive trauma in the bones, you have scattered the bone, shattered the bone, then you should have to wait for more than even 7 days. Otherwise, for adult, when you start 0 to 4 or 5 days. And if traumatic corticotomy, then you should have to wait for more than 7 or 8 or 9, maximum 10 days maximum. For children, you have done the corticotomy today, you start day after tomorrow. This teaching from my chef's off, and I do it for the children. 7 days, 7 years, 8 years, even 2 to 3 years child. You go, today you have done, 1 day stop, next day you go for destruction. Okay, these are the main things. Now, regarding the rotation of the nuts, we are using 4 times that we are usually using here. But there is a 1.125 multiplication by 8 times. That means you are getting 1 millimeter. 0.125, 8 times a day, 3 times 24 hours. Okay. And this is also, it gives, less pain when you are giving more times of destruction. Rate and rhythm is also very important. In automatic destruction, you can mention that this 60 times a day, this is a costlier apparatus. 60 times a day, it automatically destructs. It's automatic. But I am using here for lengthening, cosmetic lengthening, 8 times a day. That is 1.125, 8 times a day. And we are giving only 4 times a day, 8 in the morning, 12, 8, 4 and 8. Okay?
4 and 8.
So 4 and 8. So these are the main things. Now, regarding the corticotomy, there are lots of methods. I strictly follow the method of Professor Ilizarov. Now, in Kurgan Center, Novikov, Konstantin Igorovich, he has developed a corticotomy that I have shown to Nazmul Dashetu. He knows that one. Very simple. We know what is corticotomy, low energy osteotomy with the preservation of periosteum, endosteum, and bone marrow. But sometimes you cannot follow that one. We are distracting the cavity also. So you must respect that one. Very small incision. This is your bone. This is your bone. You make a small incision and then turn your osteotome like this. And I always use the serrated osteotome. And this serrated osteotome was created by Professor Murjikov. You have not seen, he died 2-3 years back. Shigurov and Murjikov, they have combinedly that one invented, this one serrated. Serrated, why serrated? When your bone is cortical, it doesn't slip. The serrated, it stops the cortical bone, and gradually you can osteotomize from the medial side, in center, laterally. If your bone is 2/3 breaks, 1/3 remains, then you can rotate and you can do it very nicely. Regarding the corticotomy, you should have to be very much cautious, not too large incision. Traumatic corticotomy, you must respect the soft tissue and the bones, and you cannot use the oversized osteotome. 10 millimeter maximum osteotome. Destructive hemorrhage you cannot do. You must respect the bone. And injury to the vessels and nerve, you must make it, once it happened in Nitor during my stay here, some surgeon was done, and that was a very devastating case. Vessels of the femoral vessels was injured. And nearby vessels, you must pay attention when you are doing the corticotomy. And everything, I think so, is okay. And incomplete corticotomy, whether you have, sometimes it happens, you have done the corticotomy and you have seen in the x-ray or in the, sometimes it disturbs your C-arm and x-ray. If you see, then next time you can take the patient to the OT, I can do it corticotomy. Nothing to be worried there. So these are the main things, or probably I have already mentioned. Is anything left? I can continue later on. Now, floor to the participants. Okay.
Thank you, sir, for your nice interaction, and especially the vast experience that you got in your long clinical practice. Every time it enriches us, and we get the new information. And now I got some question in the message box. Before going to the message box, I just I am seeing that two-person puts his hands up. So I want to go to that person to he can question directly to the speaker, and also if necessary to other participant. And there is an announcement for everyone that the corticotomy, the technique of corticotomy, is a very crucial issue for Ilizarov fixation. So I want to connect with different participants from home and abroad. They are regarding their experience, how they do the corticotomy, and what is their experience regarding the outcome of the corticotomy. And now I am going to Abdullah Ghaffar. Please unmute your microphone, and you can have your question directly to the speaker. Abdullah Gaddafi. Sorry, Abdullah Gaddafi. Abdullah Gaddafi, sir.
Yes. Hear me?
Yes, sir. We can hear you, sir. Please.
Yes. I want to give thanks, Dr. Abdullah, for your nice presentation. Now my question is, why corticotomy done at the metaphyseal area? Hello. Hear me?
Dr. Abdullah, can you hear?
Yes, I can hear. Thank you, Dr. Abdullah Gaddafi.
Why corticotomy done at the metaphyseal area?
Okay. I have already heard your questions.
Thanks.
Thank you, Dr. Gaddafi, for your nice questions. Previously, I have told in my session that corticotomy is usually done at metaphyseal region. In histology of bony neurogenesis, here many mesenchymal tissue present in metaphyseal region, and between the diaphysis and epiphysis, in this region, growth plate also present. So this is the crucial region of a long bone. Here, due to the presence of mesenchymal cells and presence of much circulation, so the bony lengthening procedure occurred here. So we follow the corticotomy procedure in this metaphyseal region. Thank you.
Thanks.
Abdullah Ghaffar, sir, do you want to ask any complimentary question, sir?
No. Thank you.
Bari, sir, I just asking for your opinion regarding the corticotomy in metaphyseal region. What is your opinion, sir? Do you?
This is metaphyseal region. One answer: vascularity is here. Metaphysis. This is not the diaphysis. Bone is soft. Vascularity is rich, very much, and you can do anywhere in the bone. But here, when you are after doing in the metaphyseal region, doing the corticotomy, when you are applying distraction, you are getting good callus formation here. You can hypertrophic callus, just like massive callus. But if you do corticotomy, sometimes we are doing, and we have the cases. We have done a lot of cases in the metaphyseal, not only in the metaphyseal, diaphyseal region. Also, you are getting a good, even diaphysis, two-level osteotomy, we are getting good results. It depends on your not only doing the corticotomy, stability and rate and rhythm of the distraction, and the bone quality and the age of the patient. Everything depends on. So metaphyseal region, only the vascularity is good here, and the bone circumference is wide. That's why it is very good for doing corticotomy. And regarding the corticotomy, lots of people in the world, we are also using doing the drill bit hole, that is, and with wires, that is called Abdullah Sattar or Afghan method. You can go for weakening the bone, for drilling the bones with K wires 12 millimeter, or simple the twisting drill bit. You can weaken the bone, then you can do the corticotome. With simple osteotome, you can do that one. There are a lot of methods. And regarding the giggly saw, that is with wires, there is a publication by John Hargenbach, pediatric orthopedic surgeon from Maryland. If you do these wire corticotomy, that means giggly saw corticotomy, it gives thermal necrosis of the bones, and you don't need to do that. And most of the Professor Kevin Tates was from Australia. He likes to do this corticotomy by giggly saw. And now it depends only if you follow everything, the result will be good. Otherwise, you'll face problem. Thank you very much.
Thank you, sir.
Thank you, sir.
হ্যালো আরিফ ভাই শুনতে পাচ্ছেন?
Sorry.
হ্যালো আরিফ ভাই শুনতে পাচ্ছেন?
Shunda, who is calling?
Yes, Dr. Abdullah Gaddafi শুনতে পাচ্ছেন আরিফ ভাই?
Yes.
শোনা যাচ্ছে তো।
I can hear you. Your microphone is.
জি আমি বারি স্যারের সাথে একটু কথা বলতে চাই।
Yes, sir. Yes, please.
স্যার আমি ডায়াবেটিক ফুড পেশেন্টদেরকে, আমি তো ডায়াবেটিক ফুড সার্জন হিসেবে কাজ করছি স্যার। তো সেক্ষেত্রে এলিজারভ টেকনিক এট দ্য ডায়াবেটিক চারকোট ফুড স্যার, এই বিষয়ে যদি ইউজ অফ এলিজারভ এট দ্য ডায়াবেটিক চারকোট ফুড স্যার, এই বিষয়ে যদি একদিন প্রেজেন্টেশন দেন বা কোনো হয় স্যার, তাহলে আমাদের জন্য একটু উপকার হতো স্যার।
Of course. We'll go that one later on, okay? And we are doing a lot of diabetic cases. By Ilizarov.
মানে প্রচুর পরিমাণে ডায়াবেটিক চারকোট ফুড স্যার সারা বাংলাদেশেই পড়ে আছে। তো আমি
you keep in touch with me after the conference. You keep in touch with me. You phone me. Don't hesitate. Let us have a talk. Then I will help you.
Thank you, sir. Thank you, sir.
Okay.
Thank you, Abdullah Gaddafi, sir.
Abdullah Gaddafi, Rana.
Gaddafi, for connecting with us. And now I am going to Dr. Samsuluddha, sir. If please unmute your microphone and please share your experience regarding the corticotomy.
Hello.
Hi, Samsuluddha, sir.
Yes.
Yeah. Hello, sir. Hello, Bari sir. How are you, sir?
Yes, sir. Fine.
Yeah. Thank you for a wonderful session. Dr. Arif, Dr. Bari, it was a wonderful session. I could not be in the full session because I was at the hospital only.
Sir,
Okay. So I couldn't hear the whole session, the lecture.
Can you please share your
wonderful session?
corticotomy?
Yeah. Hello.
Yes, sir.
I couldn't hear the lecture because I was at the hospital. Yeah. My voice is clear?
Yes, sir.
Yes, clear.
Clear, sir.
Yeah. Thanks, Dr. Arif.
Yes, sir.
Actually, right now I'm at hospital, so I couldn't hear the lecture.
Okay,
so
sir.
I'm unable to comment about the lecture right now.
Okay, sir. I will come back to you a little later, and I am seeing that Dr. Rashid Hassan Rani just puts his hand up, and I think he has a question. So I asked him to unmute, and you can have your question directly to the speaker. Rashid Hassan Rani.
Yes. Thank you, Dr. Arifudjaman. Can you hear me?
Yes, we can hear you.
Okay, thank you, sir. First of all, I want to convey my respect to all, especially Professor Bari, sir. Assalamu alaikum, sir.
Wa alaikum assalam. I am listening. Wa alaikum assalam.
Okay, sir. Thank you. Dr. ASM Abdullah, in your presentation, you have mentioned, and all of we know that we give distraction 1 millimeter per day. Why we do not give distraction more than 1 millimeter per day? This answer of this question already got from our Professor Bari sir additional speech after your lecture. My question is to SM Abdullah: if a patient give more distraction than 1 millimeter per day, then how can we manage this? Dr. Abdullah, got my question?
Okay, okay. Thank you, Rashid Hassan Roni,
Yes, yes.
for your nice comment. Professor Barisar already have told us the optimum rate and rhythm of destruction osteogenesis, and also we know if the patient will destruct more than 1 millimeter, then what will be done? Is it your questions, Ronnie?
Yes, yes. This is the
Yes.
question.
Okay. We know the optimum rate of destruction 1 millimeter. It is widely followed in the orthoid of all Ilizarov surgeons. If there will be delay of newborn formation, if the patient will destruct more than 1 millimeter, we tell the patient the destruction will less than 2 millimeter, will follow 1 millimeter per day, and we also advise this patient delay some days and follow the X-ray. What will be the condition of callus formation? I also request Dr. Arif, Dr. Najmullah Setu, some adding the information.
I'm requesting Dr. Nazmullah Dashadu, what is your experience when your patient come to you after just doing mistake that give more distraction? You that in 1 week there is distraction is around 2 centimeter. What is your measure to prevent it? I think question from Rashid Hassan. How do you manage this type of distraction problems? Nazmullah Dashadu, can you hear me? Nazmullah,
can you hear me?
Yes, sir, I can hear you. Please.
Okay, thank you for the question from Rashid Hassan Roni. Actually, when distraction is over the expected rate, then there is a gap, and tissue generation, histogenesis do not pace with the regeneration. In this time, then I advise the patient to stop here and wait for some time. If the callus is formed and there is no problem, if it is not come to the point, callus is not so much, then we go back again to the point where the callus is coming. Then again, destruction will start from here. Got the answer? Okay.
Yes,
Arif,
Nazmullah. Yes, sir.
Can I add with this the question? If you want to tell,
Hello,
if you allow me, I can give
Yes,
the
sir.
answer of this one.
Yes, sir. Definitely, sir.
This is for discussion. Whenever you are giving more distraction, sometimes patients is doing that. Even the doctor also do that. And what you are getting leads to failure. Faster lengthening, you must keep it in your mind. Faster lengthening can lead to failure of bone formation. Once you are looking that you are a scanty callus, very simple thing. Take the autologous bone or a blood, 5 or 7 cc, and put that in that region, and you'll get a good callus. This is one. Another one, Shetu told you stop for 2-3 days, 5 days, maximum 10 days, and wait. You can go for a little bit accordion method, a compression, and then you go for a little bit distraction. This is accordion method, compression and distraction. As a result, there is a ionic changes of that region. They are all doing kill bill, and you can, after a few days, you can go for again distraction. You'll get a good, and go for the X-ray, and you can take the decision. But blood, autologous blood, this is a very good thing. This is also taught by Shepsov, autologous blood. I'm doing that.
It is new information to us, sir. Autologous
thank
bone
you.
graft.
Thank you, sir.
Not bone graft,
Blood, sir.
blood.
Thank you, sir, for your nice comments and newer thing that is can be aspirated and injected at the distraction site. And I want to add something that you may know that the first discovery of the distraction osteogenesis comes from a mistake procedure. Ilizarov told a patient to compress a fresh fracture, but inadvertently the patient doing the opposite. And after some days, when the patient come to Ilizarov, and he found that there is callus formed in the fracture site. So it was the so far very popular story about how the distraction osteogenesis come to the scientific evolution. And this type of things usually happen very frequently. But you know that distraction, with distraction, there is a huge distraction resisting force working in the thigh or in the neck, especially from the muscle from the anterolateral and posterior part. The patient usually feel pain during this type of huge distraction. And even sometimes the patient are not motivated, or patient can just ignore and have the very high dose of painkiller. Patient can ignore this type of pain or even the distraction pain. So if the patient come at this point, what you will do? Usually my clinical practice, I usually stop for rest for the patient for a few days. And you can go back to the distraction site where you started this type of more distraction. And you can the information that if you compress the distracted callus, or even in the time of distraction osteogenesis, you may halt in any place and go back for 1 or 2 days and can start again. This type of accordion procedure, or this type of stop distraction, go to compression and the distraction, this type of procedure cause the microfracture in the distracted callus. This microfracture or microtoma is also a stimulus for bone regeneration. So if this type of faulty technique, the more distraction happened in your patient, don't worry, just follow the patient and also follow the X-ray. And there is a nice topics from your presentation is that I think this could be a also matter of discussion for all of us. I will go to my Professor Bari sir later on about if you got the poor callus, that is the pencil shaped or pillar shaped or other callus, what will your subsequent strategy to make the good callus and consolidation? I think that we will discuss this a later part of this presentation. And before that, I will go to the chat box. There are some questions waiting for us. And if Abdullah, Dr. Abdullah, if you follow the our message box, you can see that Dr. A.K.M. Harun, he have question in distraction osteogenesis, if the angiogenesis or pillar callus form, then what will the next management? I think that the same thing I just a few just before that, this is another burning question for most of the participants. So we will discuss this in a very elaborate manner. And question from the Rashid Roni already done, and one question from Zakir Hussain, multifocal corticotomy. And Dr. Abdullah, Zakir Hussain just interested about multifocal corticotomy. Can you please make some comments about the multifocal corticotomy, Abdullah?
Thank you for nice questions, Zakir Hussain. Corticotomy may be unifocal, bifocal, multifocal. If the gap of the long bones is more, then we do multifocal corticotomy. Here the multi-stage in onsetting, multiple corticotomy done through lengthening of this long bone. Thank
Abdullah,
you.
Okay, I want to add something with Dr. Abdullah, that multifocal corticotomy, usually nowadays different author from Kurgan Center and other part of the world, they are trying the multifocal corticotomy. You got the information that corticotomy is best place for corticotomy is the metaphysis of a long bone. But in case of multifocal corticotomy, you should also include the diaphyseal lesion.
Diaphysis.
Yes, this area is not a corticotomy. It is usually osteotomy procedure. You can do 2-3 osteotomy or with osteotomy and corticotomy combined in a long gap. Usually when the gap is more than the 6 centimeter, more than the 6 to 8 centimeter, there are different little bit difference in the literature. Usually these sorts of defect, long bone defect, usually treated with this type of multifocal corticotomy. And even every corticotomy, you will increase the length about 5 to 6 centimeter, not more than 5 to 6 centimeter. So you calculate your gap and just calculate the number of the corticotomy, and then you just design your frame and design your osteotomy site, and you can go this type of bone transport. This is a very good form of bone transport. And usually if you go from one corticotomy site for more than 8 to 10 or even more than that centimeter, usually this is theoretically possible. Even there are many references that Kurgan Center and the other part of the world, they have distracted one corticotomy site with a huge rate of huge lengthening, gain of lengthening. But the quality of bones, the external fixator times and consolidation times, you should keep all the things in mind. So that now the trend all over the world, why the Western people are just they are trying to build up a new strategy, that they want to put external fixator very less time and supplement the external fixator with the other type of internal fixation. It is popular in many parts of the world. And main idea is that you have to keep short your external fixator time. And for this reason, you can go for the multifocal corticotomy. And for multifocal corticotomy, the distracted bones, you know that if you have the clinical experience of Ilizarov surgery, your distracted bones is very much consolidation and is demodeling is very, but your fracture site is still in non-union. This type of things happened many times in your clinical practice. So always the corticotomy or osteotomy distraction is a very good clinical solution for this type of gap. And you can try it. And if my professor Bari sir want to add thing with the multifocal corticotomy, you can add
this
yes, sir.
Regarding this, lot of orthopedic surgeons, they make mistakes regarding the unifocal, bifocal, and trifocal.
Yes, sir.
Unifocal, bifocal, and trifocal. Do you have idea, most of the orthopedic surgeons here? Abdullah, for discussion, do you have any idea regarding the bifocal and trifocal?
Bifocal means corticotomy at metaphysis at the upper and lower end of the long bone. And
upper and lower, this is bifocal.
Bifocal.
No.
Am I wrong, sir?
Wrong. That's why I'm asking. Trifocal means, I'm telling you now, listen.
Okay, sir.
Unifocal corticotomy means there is a 3 centimeter gap. You have fixed that one, the non-union side one time, aligned, and then go for metaphyseal corticotomy, lengthening. 3 centimeter, you have aligned the bones, then 3 centimeter shortening. Then if you do the corticotomy in the metaphyseal region, go for lengthening, this is called unifocal corticotomy. One time alignment, corticotomy. Bifocal, you have a big gap, 6-7 centimeter. 6-7 centimeter. You do the corticotomy, you are going for lengthening, compression and distraction. The distal gap, this is called the focus. Pratham corticotomy, first corticotomy, and then compression destruction, you are filling the gap, that is called bifocal. Trifocal means proximal corticotomy, distal corticotomy, and more than 7 centimeter, 8 centimeter gap you are filling, that is called trifocal. Tri means first cortex, last cortex, gap. You read my publication trifocal in a medical journal in March of this month. Medcrave, you search, you will get it. Okay, Medcrave. So these are the three terminologies. Most of the time we, mistake this, what is by unifocal, bifocal, and trifocal. Very common, everybody is doing that. So nothing to be worried. You understand clear now?
Okay, sir.
Or you want to add something?
Sir, I want to add something. Also, I have a question to you. Usually, many of us do the mistake. He do not just get the idea of there is a sense of osteosynthesis. If you think that osteosynthesis, then you can calculate all the focal point. 2 focal point for distraction and 1 focal point for compression. And usually this is called trifocal osteosynthesis. And if I am not wrong, you can just label this how many corticotomy you have done. 1 corticotomy, 2 corticotomy, or 3 corticotomy. This is another nomenclature.
This is another issue.
Is the types of yes, sir. And what is the types of osteosynthesis or compression distraction osteosynthesis? Then you can label this rightly, as you said that it is bifocal, it is trifocal. When there is compression site is 1 focal and the distraction site is another focal, and you can just count how many focus is there. Then you can have the idea of how many focal distraction compression osteosynthesis is there. So I think, sir, do you want to add anything, sir?
Okay.
Sir? Okay, sir.
Okay,
sir,
okay.
Now I think
proceed.
And there is another question from another question. What will be the distance between the 2 segments of bone in case of multifocal osteotomy? Okay. Abdullah, can you get that question? It is from the Galaxy 9. I think the ID of participant is not there. There is a question, you can see it in the chat box. What is the distance between the 2 segments of bone in case of multifocal osteotomy? Abdullah.
It will be maybe 3 centimeter, around more or less 3 centimeter gap in multiple osteotomy.
I
more
think
than 5 centimeters.
Is like,
sorry, at least 5 centimeters.
Amiru sir wants
at least 5 centimeters. At least 5 centimeters.
Bari sir, can you do you want to add, sir?
2 to 3. 2 3.
Sir, usually this is a debatable thing. I asked this question directly to one of the professor who is doing the large gap non-union or gap in the long bone. I asked him what is the lowest distance between the 2 corticotomy sites. But I got the answer. I am going with the Amirusan sir. It is about the 5 to 6 centimeter.
Yes,
at least.
More than 5 centimeters.
Yes, sir. It is 5.
It depends. It depends, Arif. It depends on your bone, yes, and where is the damage, where is the non-union site. That's why I have I have done the cases 2 to 3 centimeter with multiple corticotomy. I have the documentation.
Thank you, sir, for enriching from your clinical experience. Sir, what is your idea if suppose that in a proximal part of the tibia there is very little amount of bones is left? What is your
very little means how much centimeter you must mention?
Sir, just think about that. Just 2 or 3 centimeter just below the tuberosity. It is left. What is your advice regarding this type of corticotomy in this critical
below the tuberosity?
Yes, sir.
3 centimeter.
Yes, sir.
Is very enough. Is enough for doing the corticotomy.
Yes, sir.
From
Sir,
the tibial tuberosity, 3 centimeter distance is enough for doing the corticotomy.
thank
You
sir,
can put. See,
I think just below the tibial tuberosity is the best.
no, 3 centimeter. He is telling that is just below the tibial tuberosity. That is the ideal place.
Ideal, yes.
2 to 3 centimeter from the tibial tuberosity. But Arif is asking, the question is how much you allow after the tibial tuberosity. The question is like this.
Yes.
Arif?
okay, sir. Yes, my question was like this. And sir, now I'm going to the second part of our discussion. You already saw the types of callus. And what I am going personally with different participants. I am going to Amiruddin sir firstly. What is your strategy if you got the very poor callus regeneration in your destruction osteogenesis?
Thank you, Dr. Arif. I think when there is no bone formation weight and usually not 12 hourly, but 12 hourly or daily 0.25 millimeter per day, or sometimes occasionally stop the destruction for a few days. That is beneficial for callus formation, and that a good procedure, I think.
Okay, we got the opinion from Amiruddin sir. I will come back to Mofakar sir at the last of the all opinion. What is your strategy for potentiating or increasing the regeneration in a poor callus condition? And now I want to go some foreign participant. What is his strategy regarding this?
Dr. Arif.
Yes, sir. Yes, sir.
Just I want to mention one thing that we already discussed about the multifocal corticotomy.
Yes, sir.
Before going to the overseas attendance, just you should mention here that our question from multifocal corticotomy question from Zakir Hussain. Maybe he is our resident in Nito is doing.
Yes,
so message should be clear to the doctors for the multifocal corticotomy. Actually, I think Dr. Zakir want to know about the multifocal corticotomy, when we need to do it, what is the maximum gap, what is the minimum portion of the bone, and when it will be it can be done. This message should be clear to them.
Yes, sir.
If you kindly again this answer you give them, they will be clear, I think.
Sir, I think Professor Mofakal Bari will correct me. I am stating the when multifocal osteotomy and the terminology and the clinical impaction, and when we can do this. Dr. Rashid Hassan Rani, I asked you to please stop your screen share. I don't know why it is coming. Now, for Zakir Hussain, all the participants, I asked for please attend, be attentive to me. Usually, when the gap is more than 6 to 8 centimeter, you can consider about the multifocal corticotomy. The multifocal corticotomy nomenclature can be defined in two terminology. If you get the terminology of compression destruction, type of compression destruction osteosynthesis, then it is one terminology. And if you just term this as how many corticotomy you have done in this area, it is another terminology. So if you just for compression osteosynthesis terminology, the compression site is one focal point and other corticotomy site is another focal point. Suppose that if it is two corticotomy site and one compression site, it will called as a trifocal compression destruction osteosynthesis, trifocal. Or you can label it as just what are the count number of the osteotomy. It is osteotomy number is 2. In that sense, you can label it as bifocal corticotomy or bifocal osteotomy. Usually you have to follow the author's rule, how the author label this type of corticotomy or this type of, how does he mention as is osteosynthesis or compression destruction osteosynthesis, or does he just label it as a corticotomy or osteotomy site. So it depends on the authors how he just define his performance. And other thing is that how much bones should be left between two corticotomy or two osteotomy. As my professor Bari sir, he has vast majority of experience. He added that at least 2 to 3 centimeter. But some of the participant and Amir Hossain sir just added that at least 5 to 6 centimeter bones to be left between the two corticotomy site. So, and even my opinion is that you are a beginner or newcomer. So when very less amount of bone is left for corticotomy, we may face it is difficult. So my advice is that it is 5 to 6 centimeter. So it can vary from person to person and depends on the skill of the person. And so, sir, do you want to add
even for clarification, clear conception, yes, don't misunderstand the unifocal, bifocal, and trifocal corticotomy. This is quite different thing. This is quite different thing. This is just now I have drawn this picture.
Yes, sir.
Can you see this one?
Sir, sorry, sir. I will just enlarge your point, sir.
Can you see this? Just now I have drawn this. First one, see this one. This one I have fixed this one. This is corticotomy. This is unifocal. This is very give 6-7 centimeter. Then this is one focus. When you are distracting, this is another focus. This is 1, 2. This is trifocal. Lots of the people, orthopedic surgeons, they are calling this is bifocal. No, this is the focus one. The another focus. This is trifocal. So read my publication in American Medcrave latest. Okay.
Actually, we always mean the corticotomy site, number of corticotomy site. We use it as a.
No, this is not able. This is Ilizarov.
Okay.
Thank you, Bari sir. এটা আমার মনে হয় আপনি যেটা বলছেন ঠিকই আছে. This is
you read my article, American Journal, Medcrave.
Trifocal osteogenesis, but bifocal corticotomy. Trifocal osteogenesis. Bifocal.
Sir,
osteogenesis, listen, osteogenesis and osteosynthesis, all trifocal, bifocal, unifocal, this. Osteosynthesis means ki, সংযোজন.
Yes.
Osteogenesis, new bone formation, then সংযোজন. It's all the same.
But bifocal corticotomy, trifocal osteosynthesis. But
no. Again, you read this. My book. They cannot publish when this is not authentic. Peer review, American Journal. Read it.
Okay, sir.
Okay, thank you. Very good discussion. Very good. Lovely discussion. Very good. I like it.
And even,
we enjoy this, sir.
Even the confusion is all over, and I'm just at the last part of the statement to Zakir, sir. Yes, sir. To Zakir,
Arif, another complementary question. Arif. Another complementary question. The multifocal or bifocal or trifocal corticotomy can be done at the same time or in different time?
Yes, I'll give you the answer. You'll hear my lecture day after tomorrow. Day after tomorrow, deformity correction, which I live. You'll get all the answer.
Okay,
single corticotomy, bifocal corticotomy, multi-apical corticotomy. You'll see that.
Okay. I think we'll just keep the discussion for our Professor Mufakal Bari sir presentation.
Deformity correction.
Deformity correction. It is on 9th of this month.
I think that will be clear for you when I'll go for deformity correction.
Sir,
Thank you, sir.
I am just going to you for your opinion about the whole of the session and the.
You ask Amir Hussain, and Golam Farooq কোথায়? You ask the Golam Farooq.
না ঠিক আছে বাড়ি স্যার
Sir, Amir sir is very-
They're all good
Okay,
junior
okay.
friends. No problem.
Thank you.
Tell them to. Okay, thank you very much.
You are the
Abdullah.
pioneer and
Sir.
you are the teacher of us also. And
No, thank you
you conclude this
very
session.
much. Thank you very much. We are enjoying. They are very much enthusiastic, and I love to hear all from the junior colleagues. I want to learn from you also. So let us have a discussion. Don't take it otherwise. If any question arises, you can talk with us. No problem. I see 21, including international participants. Very good. Thank you very much. Thank everyone.
thank
Arif, Amir Hussain, Abdullah, Shetu, then Abdullah Gaddafi. He asked the question. It's very good.
Accord.
So Ilizarov, you know, you must keep it in your mind. Ilizarov is a so fantastic technique. I cannot make you understand. Those who has got the taste of this one, they can do anything with this technique. AO group, business. It's good. They're doing business with instruments. They have money, we don't have money, but we are getting money. They are selling money, selling the instrument, getting money, and we are treating the patient and getting money. And we are deformity correction in every chapter of the AO book. I have AO books. You can see they have mentioned every deformity correction in the knee, in the hip, in the ankle. The Ilizarov is obvious. They have written in AO book. In AO book, you know. So try to learn meticulously.
Sir,
And,
I want to add a question to you, sir. That was just a discussion left. If the poor callus, what is your strategy to boost it up, sir? Please
poor
also-
callus after how many days?
After just think about the 1 or 2 months of the distraction, there is the pain.
Yes. Listen, depending upon the poor callus of the age of the patient, I again go for drilling with the K wires inside the bone, or the proximal bone, lower part, upper bone, lower part. I do the, drilling of the bones by K wires to increase vascularity. I go for the autologous blood. And at the same time, you can see in the shapes of two level, you don't know, lots of tricks in the Ilizarov. Metaphysical region, I go for drilling here, directly. And distal part, metaphysical region, go for drilling here. Then you can get the vascularity here. And after 2 or 3 months, you just check. If not, then you could go for compression or distraction maneuver method. Or you can
Accordion maneuver.
Accordion maneuver. Never use bone grafting. Lot of our, many of our Ilizarov surgeons, those who are young, they don't have idea. They are doing bone grafting. Why? You are violating the rule. Why you are giving bone grafting in Ilizarov? I don't know. You're not respecting the methodology. You are doing whatever you like. No, this is not. You must respect the principles of and philosophy. Ilizarov is not the only putting the words. This is a philosophy. You must understand what is that I'm telling you. And that is, you should have to introduce in your mind what is Ilizarov. Very vast thing and fantastic thing. Why the Western world deviated from this? Because of Russia, nothing else. But they accept. Whenever you address them, they just listen. Oh, what he's showing is good. This is I myself the example. Always I tell them, see, look that they don't, in front of me, they don't talk. Because originally it should be love. And all Western people, they are doing all the time hybrid. The product of a cross between genetically unlike individuals, that is called hybrid. What is hybrid? The product of a cross between genetically unlike individuals, that is called hybrid. Hybrid is never good. And sometimes you can get result. Okay?
Sir,
thank you very much.
I think I have another question from your audience. Just I am throwing to you, sir. Dr. AKM Haruna Rashid just have question that if gap non-union in metaphysis, then how can you perform bifocal or multifocal corticotomy, sir? It is a question from the Haruna Rashid. Sir, you can have comments on this.
What is the size of the metaphysis? You ask it.
Sir, I think I am asking to Dr. AKM Haruna Rashid. You can WhatsApp your message to me, and we can discuss this issue, because you know that our Professor Bari sir have also the slides on multifocal or multifocal corticotomy on the deformity correction. So we can discuss this again. And this question, please send me the question in WhatsApp. And Bari sir, from you, I will go to the Samsuluda sir for some technical issue. And after that, we will conclude the session. Sir, you can add some comments of the overall session. And we are just at the end of the session, sir. Bari sir, can you hear me, sir?
You're telling me?
Yes, sir.
Yes.
Samsuluda is here?
Samsuluda sir, please unmute your microphone. Samsuluda sir, are you here, sir? Samsuluda sir.
Still 21.
Yeah, hello, can you hear me?
Yes, sir. We can hear you, sir.
Hello?
Yes, sir. We can hear you, sir. So, sir, we are at the end of the session. And if you want to add anything, you can add with us. And then I will deliver the host status to you, and we can conclude the session. And Bari sir, if you want to say anything, you can.
No, I have already said. Thank you very much. Thank you, everyone. Try to join in deformity correction after tomorrow.
Okay, thank you.
Yes, sir.
Thank you, Dr. Arif. Can you hear me?
Yes, sir.
Yeah,
I can hear
actually,
you.
at hospitals, so my internet is not very fast. So I'm just here to stop the live session. I've heard a little of the session. It was a wonderful session, a wonderful discussion by Bari sir and Arif. It was a real learning, and I'd like to come to Bangladesh to learn more from Bari sir.
Welcome, sir.
Okay. Thank you.
Thank you, sir. Thanks a lot.
Thank you very much, Shamsuruddha. Very good. Thank you.
Sir, you can stop the live transmission.
Okay.
And I send the host status to you, sir.
Okay, I'm just ending the live session. Thanks a lot from Ortho TV and Ortho Worlds.
Yes, sir.
And